Hi, I'm Genesis Salvador, and today I'm going to tell you a little about sodium zirconium cyclosilicate for urgent therapy of severe hyperkalemia. Introduction. Severe hyperkalemia can cause lethal cardiac arrhythmias and represents a medical emergency. Existing therapies do not remove excess potassium, have uncertain short-term efficacy and poor safety profiles, or are invasive and costly.
The average daily intake of potassium is approximately 100 millimoles, which equals 3.9 grams or 3,900 milligrams. However, less than 2% of American adults consume the recommended daily allowance for adults, which is 4,700 milligrams or 120 millimoles of potassium. There are two ways to fulfill your recommended daily allowance. That would include eating enough potassium-rich foods or taking a potassium supplement. Now, if you ate 1/2 cup of baked beans, 1 potato, 1/2 cup of dried apricots, 1 cup of yogurt, 3 ounces of tuna, 1 cup of whole grain cereal, and a medium-sized banana, you would reach at least 100 millimoles of potassium intake. So, once we consume these foods, where and how is potassium absorbed along the GI tract? Well, of the 100 millimoles of potassium ingested, 77% is absorbed along the small intestine, 13% is absorbed along the large intestine, while 10% is excreted in the feces. So how is potassium absorbed along the small intestine? Well, potassium absorption across the small intestinal epithelium is passive and occurs via the paracellular pathways. In other words, it passes between the cells and tight junctions, and absorption is driven by the electrochemical gradient. For example, following the ingestion of potassium, the potassium ion concentration within the lumen of the small intestine will be significantly greater than that of the potassium concentration of the extracellular fluid space. It is this difference that provides the driving force for the movement of potassium between the cells of the small intestine into the extracellular fluid space. So, how is potassium absorbed along the large intestine? Now, potassium absorption across the large intestinal epithelium occurs via the hydrogen-potassium ATPase, which requires energy in the form of ATP. The hydrogen-potassium ATPase transports one potassium ion into the cell in exchange for one hydrogen ion. Once inside the cell, potassium uses the electrochemical gradient to passively exit the cell via potassium channels located in the basolateral membrane. Now that we know where and how potassium is absorbed along the GI tract, let's address the following problem.
Where is hyperkalemia? If you have hyperkalemia, you have too much potassium in your blood. The body needs a delicate balance of potassium to help the heart and other muscles work properly. But too much potassium in your blood can lead to dangerous and possibly deadly changes in heart rhythm. Causes. Kidney disease is the most common cause of hyperkalemia. Your kidney help control the balance of potassium in your body. If they don't work well, they can filter extra potassium from the blood or remove it from the body. A hormone called aldosterone tells the kidneys when to remove potassium. Diseases that lower production of the hormone, such as Addison disease, can lead to hyperkalemia. Too much potassium in the diet can also contribute to higher levels in your blood. If your kidneys don't work well or you take certain medicines, salt substitute typically contain high amounts of potassium. Foods such as melons, orange juice, and bananas are rich in potassium too. Symptoms. Potassium helps your nerves fire properly so that they respond to stimulation. Again, this happens via electrical signals that travel from cell to cell. As part of the nerve system, your brain also needs potassium. The mineral allows brain cells to communicate both with each other and with cells that are farther away. Changes in potassium levels have been linked to learning the rules of hormone and metabolism. Applied in medicine. Sodium zirconium cyclosilicate is a highly selective cation exchanger that entraps potassium in the intestinal tract in exchange for sodium and hydrogen. In a phase 2 study as compared with placebo, was associated with significant reduction in serum potassium levels within the first 48 hours of treatment in patients with stage 3 chronic kidney disease, and serum potassium level of 5 to 6 millimole per liter.
Okay, our next patients dealing with hyperkalemia, which is the condition of having too much potassium in the blood. And in this condition, you see blood potassium levels that are generally greater than about 5.1 milliequivalents per liter. And the individual in this case is feeling quite uncomfortable, fatigued, and in terms of the heart, there's irregular pulses, a widening QT wave on the EKG, so that indicates the risk for cardiac arrest. The stomach, very uncomfortable. And you see GI upset, which includes diarrhea. From here, the loss of potassium, the excess of potassium can go on to produce tingling and numbness in the extremities, and then muscle cramps and weakness in the legs. The kidneys are the next thing we're going to talk about being affected, and they begin to fail. So the consequence of that is change in the amount of urine output. Question: what are the nursing actions? Excellent cardiac assessments. This patient may even be in a monitored unit. Frequent neuro checks. Accurate intake and output. The use of potassium wasting diuretics like Lasix, and the restriction of dietary sources of potassium. So this person's not going to get that extra orange juice or banana.
Pros and cons. Pros. It will be the first treatment available that specifically binds potassium ions, leading to their elimination from the body. The potassium binding capacity of ZX9 is 9 times that of organic polymer resins. Cons. Sodium zirconium cyclosilicate is currently in one phase 3 clinical trial, testing the safety and efficacy on this long-term use. Most common it is AES, where diarrhea and urinary tract infection at all closed and placebo in both phases.
why is it reading a heart rate of 215?
Oh my God, wow, they stuck you up on.
I think it's picking up the T waves as well as the QRS complex, so it's thinking it's by Jimmy.
So you said the potassium, her potassium is 8?
Greater than
8.5.
All right,
Yeah,
Cindy,
and she's got
ready?
it, and she's got good pasture syndrome.
Sorry.
Two by carb, 10 minutes.
All right, I have a 20 on the inside of our rest.
So William, how are you treating this?
Calcium, 2 grams of bicarb, an anti-D50, and then 10 units of insulin IV.
Okay, it'll be interesting to see what happens to this QRS. Yeah.
You getting
Tell me when I can open this.
You can open it. Will you back up a little
2
bit?
grams of bicarb, an anti-D50, 10 units of insulin. And I think that's chloride. It's calcium chloride in there, right?
I peased him. Thank you.
And somebody left the Pixis open. And I saw it. I saw it all.
What are you doing? Have you done?
I've done the insulin too.
What you look like?
Nothing.
I'll tell you what.
I think you get real-time narrowing of the EKG up there.
Are you trying to come and get it?
Yeah, I'll tell you.
I love you too.
tightening up for you?
Hit the
I
head.
think it's tightening up.
Do you want me to write?
Yeah, now you've done her PTs.
Yeah.
We're gonna need.
Look at that. Look at
That
that.
20 will probably pull back.
Look how fast you're
That
changing
20
it.
in the room. She already was over. So insulin's in. You want to do it for flushes? We got a flush first.
Where's my, yeah, I do 50.
Look at your heart rate coming down because it's not picking up the peak T waves and the QRS. Yeah. Your second amp of bicarb.
This is the first
The first amp you're still giving
The
it.
other one was the dextrose.
Oh, that was the glucose. So she's got calcium to start out with.
It's going in another line.
Calcium's going in one line, the D50 includes our insulin, and
They gotta fill it.
But what caused that rapid change up
I take
there?
them out and I fill them and I flip.
Was it?
Calcium has just started. It was
Yeah.
The
right, it's
insulin
probably
and
the insulin and
the
D50, because that shifted.
Because that was already in. How long had that been in?
D50 was still being pushed, but it was almost completely pushed.
And the insulin was already in. Boy, that worked fast. I wouldn't imagine it that fast.
It's almost done.
Look at that QRS up there.
Well, no, don't throw all that. I haven't scanned any of that.
Hot off the press. Look at that. That is beautiful.
I'm gonna hit a weight, y'all.
What year is it? You got it what?
P waves. Still don't see strong P waves, but what's the story then on the potassium?
When her formal labs came back on her comprehensive metabolic panel, the potassium was 9.7. That was drawn after the treatments had been done, and we were watching her QRS narrow on the EKG.
Wow,
But it was actually probably higher than that when we started.
Okay, so as we treated her and the QRS was narrowing, we drew the blood and it came back at 9.7
Yes, sir.
potassium.
9.7. So we're repeating our treatment at this point.
Issue in Ecuador. The kidney failure is usually associated with a severe hyperkalemia from the beginning of the dementia. Approximately 1 million of Ecuadorians suffers from kidney failure.
Now you got to shift it into cellular. Now you got to take potassium and move it in the cell, and there's 3 ways to do it, folks. 3 ways. One is, we know this. We know anybody's in a metabolic acidosis, this happens. Hydrogen gets brought into the cell, and it spits out potassium. But
What if we put them into a metabolic alkalosis? Meaning that we give them a shot of bicarb. This is going to happen. Potassium is going to go back in the cell, and hydrogen is going to go back into the blood vessel. Step one is we can mess with their pH by giving them bicarb. We reverse this process. Step two is what I call osmolar shifting. Okay? If someone has a high osmolality, either because they're a diabetic and they're hyperglycemic, or we make them hyperglycemic by giving them an amp of dextrose. So we give them an amp of dextrose, we give them a shot of insulin, insulin goes in the cell, and it sucks potassium with it. So we have two ways right now to move potassium intracellular. We can change pH, or we can osmolar shift. The last one is right here, high-dose Preventil. I don't know the mechanism of that. I've heard people try to explain it to me. I'm like, I don't know. That's just one of those things that I just accept and know it's a mystery of the body. That's how I look at it. We know Preventil works. How well does it work? Don't know. How fast does it work? Not quite sure. How long does it work? I don't know. But it's an option, and it's a good option. And there's advantages to Preventil. Why? What is the advantages of Preventil over insulin glucose or bicarb? What has this one have that these two don't have? What do you think? You don't need an IV for it.
Conclusion. The results indicate that VX9 is a potent selective potassium trap that corrects hyperkalemia within 48 hours. A clinically significant treatment effect was observed within 1 hour after administration. The decline in the potassium level was rapid and dose dependent, starting at a dose 2.5 times daily.
I'm Corey Slovis from Vanderbilt Emergency Medicine. When I think about hyper-K, the most important life-threatening electrolyte abnormality is hyper-K EKG. And most of the time, our therapy is going to be directed towards driving K right into the cell. The first way to do it is with glucose plus insulin. As you give the glucose and insulin, as the glucose is driven into the cell via the insulin, you take potassium with it. And we supplement that with a beta agonist, usually albuterol, and it could be with ipratropium by mass. And in adults, most people use 15 milligrams. In somewhere between 20 and 30 minutes, these two therapies will drop your potassium by at least 0.5 and over an hour by at least 1.0. These are the two best ways to rapidly drive potassium right into the cell. There are three other ways. I want to talk about them a little bit. The first is bicarbonate. Now, bicarbonate works by exchanging hydrogen inside the cell for potassium outside the cell. When you give bicarbonate, it neutralizes the hydrogen outside the cell. Therefore, more hydrogen has to go out. K goes back into the cell. Bicarbonate is spectacular, but only if the patient is acidotic and significantly acidotic. So, glucose and insulin, albuterol, bicarbonate, only if acidotic. The dose of glucose and insulin, in general, is in a ratio of 5 to 1. So we normally give 50 grams of glucose and 10 units of IV insulin. 50 grams of glucose is going to be not 1, but 2 amps of D50. It's D 50% in W, 50 grams per 100 cc's. So 2 amps of D50, 10 units of IV push insulin. Keep in mind that in about an hour, hour and a half, you want to check your glucose because giving insulin can result in hypoglycemia later on. As far as the beta agonist, as I said, 15 milligrams, continuous mass. Bicarbonate, just like glucose, 2 amps or 100 cc's. Volume as saline is great, except most hyperkalemic patients have renal failure. Most people that are hyper-K with renal failure have volume overload. So talk to your nephrologist. You may want to just give 100 cc's to rev the pump, to drive K into the cell via the sodium-potassium pump. If someone has hyperkalemia with normal kidneys, maybe due to a drug, an ACE inhibitor, then you can give lots more saline to the cell pee it out. You put saline in the vein, they pee saline and potassium out. Fifth way, magnesium. We don't normally give magnesium in hyperkalemic patients, even though it drives K into the cell, because hyper-K, EKG, hyper-K is usually hypermag also. There are 5 ways to drive K into the cell. First 2, glucose and insulin in a ratio of 5 to 1. 2 amps of D50, 50 grams of glucose, 10 units of insulin. Be careful, an hour or 2, you might get hypoglycemia. Next, start them immediately on an albuterol mask, continuous inhalation, 15 milligrams. Those 2 things will drop K rapidly. Third, bicarbonate, 2 amps, 100 cc's. Bicarbonate, only if acidotic. Fourth, volume. Give them a couple of 100 cc's of saline. Talk to renal first if they're a dialysis patient, especially if they're fluid overloaded, and almost all of them are. If they can make urine, saline is great. Saline in, saline and potassium out. Fifth, magnesium. We love magnesium. It drives K into the cell, but hyper-K, EKG, hyper-K, also hypermag. We've done 5 ways to drive K into the cell in under 5 minutes. Thank you.